I'm Dr. Iram from Jammu and Kashmir, and my question is, sir, what's the one guru mantra for a thin endometrium in spite of adequate HRT, in spite of uterine PRP? What can be done next? This is bothering me a lot.
Yeah, guru mantra is that try to find out why is she having thin endometrium.
Normally, in spite of doing diagnostic hysteroscopy and on HP, on TB PCR, everything is coming normal, but still she is not growing her endometrium.
It's always a dilemma. We never come to know why it is happening. And thin endometrium is not only due to, it's not always due to endometrial problems. It can be due to PCOD also. When she is a PCOD patient, she'll have a, I won't call it pathological, but she'll have physiological thin endometrium because her levels of E2 are very high in the body and levels of LH are very high, androgens are high, she'll have a thin endometrium. So beware of, find out the cause of thin endometrium. Now, why does thin endometrium normally occurs? How does endometrium grow? Endometrium grows when the follicle makes enough amount of hormones, and when they act upon the lining, the lining starts growing. So when the follicles have become around 18-19 millimeter, but lining is not growing, we normally call it as a thin endometrium. So any endometrium less than 7 millimeter average they take, we call it a thin endometrium. That is okay, but true thin endometrium is less than 4 to 5 millimeter. Define thin endometrium after the follicle is around 18-19 millimeter. But only then body will have enough amount of E2 in it. Thin endometrium should be defined when follicle is mature in the body, and we hope it is secreting 150 or 200 picograms of estradiol. This is one thing is clear?
Yes.
Now thin endometrium causes can be Asherman syndrome, where we have skip lesions. It can be chronic endometritis on the other hand, or it can be PCOD. When you've got a patient with PCOD, then you have to, and they have thin endometrium. Take it very clearly. And those thin, and secondly, the thin endometriums are, they are thin. Why? They got a actually thin and disordered endometrium, or they are triple layer thin endometrium. The problem comes when we've got a triple line endometrium, which is refractory.
Yes.
You're finding 4 to 5 millimeter. It is not growing. That is a challenge which you find. Yes. When you got a chronic endometritis, you know that endometrium is damaged. When you got skip lesions, bridge lesions, we know it is a case of Asherman syndrome. It is not an issue because we know the problem. But problem comes when you are getting pathological thin endometrium, refractory thin endometrium. So here I think the right thing will be, in case you are not able to come over it, I'll say give the patient OC pills for 2 to 3 months.
Okay.
Make her bleed. Sometimes the receptors are down regulated. So make her bleed, give her OC pills for 2-3 months, and then she will start bleeding, endometrium will build up. Doesn't build up yet, then you can put in her GCSF or you can use PRP. Both the things can be done, and normally they respond to it. But in case she's a PCOD patient, what I normally do is that I do down regulation with Lupride. One cycle prior, I'll give them Deca or Lupride from day 21, and then I will start giving her HRT. They respond very beautifully. They may not respond. Then what do? Then you give them clomiphene or you give them letrozole and HMG, and make the follicles grow. So after 4 to 5 shots of HMG and 5 tablets of clomiphene, like MSP we spoke yesterday, then the follicle will form. And then you can also either trigger the follicle or the follicle rupture. That's the day of that becomes your day of OPU. And accordingly, so in case you give them clomiphene and HMG combined, that will make her follicles grow, and that will give her more endogenous E2 than ET forms. So large number of my failure cases, I normally, you can put GCSF or PRP, but I'll prefer to give them clomiphene, letrozole and HMG. Letrozole for 4 to 5 days starting from day 2, and then from day 6 I give 3 HMGs. That will make her endometrium grow. In case
and sir, plus trigger also. Plus trigger.
That you can do, but that is not FDA approved to
Okay.
be used. Many people use it while doing hysteroscopy, same thing you're saying, but that is not FDA approved for that.
Okay.
So I don't like to do anything which is not FDA approved or European Union. That is a personal thing you can do. That is not an issue, but that is not meant for this particular thing.
Okay.
So I
And
think
sir,
you give letrozole and HMG for 8-9 days, and you'll find endometrium starts growing. But for a pathologically thin endometrium, for skip lesions, you would carry out an hysteroscopy. You
Yes,
cut
sir.
the bridging lesions, and then only they will respond.
Sir, what about chronic endometritis? In
Nothing can
spite
be done.
of
Nothing can be done.
nothing can be.
Actually, it doesn't work. Nothing. See, I can't say that God has his own ways, but chronic endometritis with subendometrial calcifications, you don't have many things to offer to her. Your feelings are true, but it doesn't work out.
So in case of assurement, after doing hysteroscopy, I am using conjugated ecoestrogen in combination with medroxyprogesterone. Is it better or OCP is better?
For what are you giving? Can you have your mic, please, so we
Yes.
can listen?